We covered crystalloids, colloids. Now let's talk about blood products. Blood products are the only class of fluids that are able to carry oxygen. They increase tissue oxygenation and increase plasma volume. However, they are the most expensive and the least available fluid because they require human donors. Blood products do increase our colloidal oncotic pressure and our plasma volume. They pull fluid from the extravascular space into the intravascular space. They're plasma expanders. Red blood cell products also carry oxygen, and they increase the body's supply of other products such as clotting factors and hemoglobin. Blood products and their indications are listed in Table 29.8 in your textbook, so I would suggest take a look at that. We'll quickly go through some of those indications. Cryoprecipitate and plasma protein factors are used in the management of acute bleeding when we have greater than 50% slow blood loss or a 20% blood loss acutely. Our fresh frozen plasma is used for increasing clotting factor levels in patients with a demonstrated deficiency of those clotting factors. Our red blood cells, or packed red blood cells, are given to increase the oxygen carrying capacity in patients with anemia and in patients with substantial hemoglobin deficits, also in those who have lost up to 25% of their total blood volume. Whole blood, indicated for the same reasons as our packed red blood cells, except that whole blood is more beneficial in cases of extreme loss of blood volume, when it's greater than 25%. And that's because whole blood also contains plasma, so it expands the volume more. Contains plasma proteins, and that helps draw fluid back into the blood vessels from the surrounding tissues. Obviously, with any blood product, there's going to be a cross-match and type testing done every time the blood product is being considered. Incompatibility with the recipient's immune system is the #1 reason that we have a problem, and that can cause transfusion reaction, anaphylaxis. We can also get transmission of pathogens to the recipients, like hepatitis or HIV are bloodborne pathogens. Incompatibility, #1 problem. Our universal donor, meaning anyone can have their blood, is the O negative. And so you can give O negative, but we typically don't do that unless it's an emergent situation. So if we don't have time to do a type and cross match, we may use O negative blood. Remember, blood can only be administered with normal saline. We cannot use any other solution. It will completely destroy the red blood cells, so it must be normal saline. Let's talk about electrolytes. Now we're going to explore sodium and potassium in more depth, but our principal extracellular fluid electrolytes are sodium and chloride, and then our principal intracellular electrolyte is potassium. Others that are important are calcium, magnesium, and phosphorus. But let me give you a couple of points about calcium and chloride. So chloride is a major extracellular fluid anion. It is involved in regulating the osmotic pressure between body compartments and forming hydrochloric acid in the stomach. It's also involved in the chloride shift process in the blood, which is the exchange of bicarbonate and chloride across the membrane of the red blood cells themselves in the lungs. Calcium is the most abundant cation in the whole body, but it is located mainly in the extracellular fluid. It's a major structural component of our bones and teeth. It also functions in blood clotting, neurotransmitter release, muscle tone, and the excitability of nervous and muscle tissues. You may recall that the level of electrolytes are mainly regulated by hormones, the aldosterone, the renin-angiotensin-aldosterone system, right? That's from the adrenal cortex. That causes the increase in the sodium reabsorption and the potassium secretion at the kidney tubules. And then parathyroid hormone from the parathyroid and calcitonin from the thyroid itself, the thyroid gland, regulate the calcium balance. Calcium is the most abundant cation in the intracellular fluid. It is our most abundant positively charged electrolyte inside those cells in the intracellular fluid. So 95% of the body's potassium is inside the cell. Potassium content outside the cell, and that's what we measure when we're doing our measurements of our chemistry panels, is 3.5 to 5 milliequivalents per liter. Calcium is involved in maintaining fluid volume, nerve impulse transmission, muscle contraction, and the regulation of pH. So it's critical to normal body function. It can be obtained from foods such as fruits and fruit juices, bananas. You notice I have oranges in bold there because it's a really good source. Apricots, dates, raisins, broccoli, green beans, potatoes, tomatoes, meats, fish, wheat bread, and legumes. Excess dietary potassium is excreted by the kidneys. However, when we have impaired kidney function, we can get higher serum levels and possibly toxicity. So excessive potassium levels can cause ventricular fibrillation and cardiac arrest. Hyperkalemia, that's excessive serum potassium. That's a level over 5.5 milliequivalents. We see this happen when patients are using potassium supplements. They may be taking ACE inhibitors. We'll learn about those. That is a medication given for blood pressure. Renal failure, excessive loss of potassium from the cells, or potassium-sparing diuretics. We'll learn about those in the future. Burns, trauma, metabolic acidosis, and sometimes infection. Hypokalemia, which is low potassium in the blood, is a deficiency of the potassium with a level lower than 3.5 milliequivalents per liter. Excessive potassium loss is what usually occurs here instead of poor dietary intake. This can be from alkalosis, corticosteroid use, diarrhea, and loss of fluids, ketoacidosis, laxative misuse, hyperaldosteronism, increased secretion of the mineralocorticoids, burns, some of our thiazide and thiazide-like loop diuretics. You will learn about those later in this coursework. Vomiting, malabsorption, anything that takes out fluid also takes out potassium. So hypokalemia in the presence of digoxin therapy, meaning your patient is taking digoxin, can cause digoxin toxicity, and that results in a very serious ventricular dysrhythmias. Potassium is responsible for muscle contraction, transmission of nerve impulses, regulation of the heartbeat, maintenance of acid-base balance, isotonicity and the electrodynamic characteristics of the cell, enzymatic reactions, gastric secretions, it's an essential component of those, renal function, tissue synthesis, and carbohydrate metabolism. Our main indication for giving potassium is the prevention or treatment of potassium depletion when dietary means are inadequate, or we've lost potassium for some other reason. Other uses are to stop irregular heartbeats, manage the tachydysrhythmias that occur after cardiac surgery, and the acetate salt is sometimes used to raise the blood pH in an acidotic patient. Our adverse effects with oral preparations are usually diarrhea, nausea, vomiting, GI bleed, and ulceration. With IV administration, we may have pain at the injection site and phlebitis. Excessive administration can cause hyperkalemia and toxic effects. Cardiac monitoring is required with doses greater than 10 milliequivalents per hour. When we have hyperkalemia, we will see muscle weakness, paresthesias, paralysis, cardiac rhythmia irregularities, maybe ventricular fibrillation and death. And the treatment of severe hyperkalemia, we're going to give IV sodium bicarbonate, calcium gluconate, or calcium chloride, and maybe dextrose with insulin. We will also see an oral medication called K-exolate, sodium polyestrine sulfonate, or hemodialysis may be done to remove the excess potassium. Sodium is the most abundant positively charged electrolyte outside of the cells. It is involved in nerve impulse transmission, muscle contraction, and the creation of osmotic pressure. Our normal concentration outside the cells is 135 to 145 milliequivalents per liter, and it's maintained through dietary intake of sodium chloride that we find in salts, fish, foods flavored or preserved with salt. We'll see hyponatremia, a sodium loss or deficiency occurring with serum levels below 135 milliequivalents. Symptoms include lethargy, stomach cramps, hypotension, vomiting, diarrhea, and sometimes seizures. Some causes of hypokalemia are the same causes as hypokalemia, but also excessive perspiration during hot weather or physical work, prolonged diarrhea or vomiting, and renal disorders. Hypernatremia is when we have sodium excess or the serum levels are over 145 milliequivalents per liter. Symptoms include water retention, so we'll see that edema, hypertension or high blood pressure, red flushed skin, dry sticky mucous membranes, increased thirst, elevated temperature, and decreased urine output. Our causes are poor renal excretion stemming usually from kidney malfunction or inadequate water consumption and dehydration. Sodium is responsible for control of water distribution, fluid and electrolyte balance, osmotic pressure of the body fluids, participation in the acid-base balance, but remember it's also capable of causing diuresis itself. The main indication for treatment or for giving sodium is the treatment or prevention of sodium depletion when dietary measures are inadequate. If we have a mild sodium imbalance, it will be treated with oral sodium chloride, and it could be with a fluid restriction. When it's severe, we usually will see it treated with intravenous normal saline or lactated ringer solution. Sometimes a hypertonic saline infusion is used. Oral administration of sodium usually can cause nausea, vomiting, cramps. IV administration, we may see venous phlebitis. Now, if sodium is given too rapidly intravenously, it can also cause a condition called central pontine myelinolysis. This is where there's rapid rise in the sodium, and that causes a movement of the small molecules and pulls water from the brain cells, which causes a destruction of the myelin. You may remember that the myelin is the substance that surrounds and protects the nerve fibers. So the pons of the brainstem is particularly susceptible to this myelinolysis. Sometimes other areas are affected, and this is called extraponine myelinolysis. The damage really depends on several factors, including the rate of the infusion and the overall condition of the patient. The damage may be permanent. Initial symptoms of myelinolysis, which begin to appear 2 to 3 days after hyponatremia is corrected, can include a depressed mental awareness, difficulty speaking, difficulty swallowing. Additional symptoms often rise over the next 2 weeks, including impaired thinking, weakness or paralysis in the arms and legs, stiffness, impaired sensation, and difficulty with coordination. At its most severe, myelinolysis can lead to coma and what we call locked-in syndrome, where there's complete paralysis of all the voluntary muscles in the body, except for those that control the eyes, and it can lead to death. Although many people get this, or when they get this, or improve over weeks, sometimes it's permanent disability. So we want to be very careful that we never administer IV sodium too rapidly. We're going to talk about nursing implications, but it's going to require another audio tape. Talk to you in a few minutes.